good afternoon, and many thank you for the invitation to speak here. My name is Patani. I'm one of the breast surgeons who works at the Princess Grace Hospital, London Breast Institute, and also at UCLH Hospital. I want to talk to you for about 20 minutes about the de-escalation of breast cancer surgery. So what does de-escalation mean? De-escalation is a concept which refers to avoiding overtreatment and reducing morbidity, enhancing quality of life and safeguarding the outcome of cancer patients. De-escalation of breast cancer can be summarized in 3 words, which are less is more. The communication of this concept to patients is very important, because patients are obviously concerned about undertreatment. So I'll talk to you today about the history of breast cancer surgery. I'll talk to you about how our understanding changed, and then 3 time periods for the de-escalation of breast surgery, how we have already de-escalated breast surgery, how we are currently de-escalating breast surgery, and how the future may allow us to de-escalate breast surgery even further. So William Halsted was a pioneer of breast cancer surgery. The radical mastectomy was the standard operation for all patients with breast cancer for many years. The concept here was that breast cancer would spread from being a local disease to a systemic disease, and if your surgeon was brave enough and enough tissue was removed, you could be cured. But the outcomes from this approach were inconsistent, and patients suffered significant morbidity. There was then a landmark change in the way we think about breast cancer when the idea of micrometastatic disease was popularized. Here we consider breast cancer as a systemic disease at the time of diagnosis in essentially all patients. And the theory was that systemic treatment, which targets micrometastases, would be the ultimate driver of patients' outcome. So just to highlight the difference, macrometastatic disease is present in a very small fraction of patients. Most of our patients have local regional disease, but the idea here is that all of these patients have micrometastatic disease. So we have already, as a group of breast surgeons, de-escalated treatment significantly when we have accepted that systemic treatment drives the outcome. By the control of micrometastases, radical surgery became a thing of the past. So there were landmark studies that showed that not all patients with breast cancer needed a mastectomy, and there was no value in removing normal breast tissue. There were landmark studies that showed that not all patients required an axillary lymph node clearance, and that for the majority of patients, mapping the sentinel lymph nodes would be acceptable. So removing normal lymph nodes would not improve outcome. Now these concepts have been extended further, and in current practice, about 20 years ago, we began to understand that breast cancer was not a single disease. It is effectively a collection of diseases which occur in the breast. And there are subtypes of breast cancer which have fundamentally different biology and natural history. So we cannot use this one-size-fits-all approach anymore. So clinical patients fall into 3 groups. You essentially have those that have hormone-driven disease, which is the vast majority, about 3/4. You have a smaller proportion who have HER2-driven disease, and then you have a sort of group triple-negative breast cancer, which is not really a group which is positively defined. It is just the absence of 3 things. So it's a very heterogeneous group, and has historically been associated with poorer outcomes. But as I'll come to show you, this is now a group where we can achieve some of our best results. So the aim of de-escalation in modern practice is to combine and sequence different multimodal treatments, particularly systemic treatment and surgery, minimizing toxicity and optimizing the outcome for patients. About 20 to 40% of patients now don't have surgery as their first treatment. They receive drug therapy first, and when it's given before surgery, it's referred to as neoadjuvant systemic therapy, whereas treatments after surgery are referred to as adjuvant systemic treatment. So in the multidisciplinary meeting, there is often a friendly discussion between surgeons and oncologists about who should treat the patient first. So if you are going to de-escalate surgery, you need to carefully select patients. You can't do less for every patient. Some patients still need radical treatment and they still require surgery first. But if you pick the right patients with the right type of breast cancer and treat them with the right drugs at the right time, you can effectively turn the clock backwards. So cancers become smaller, lymph glands can become normal, and allow you to perform less radical surgery to the breast and less radical surgery to the lymph nodes. That creates another problem because cancers and lymph nodes become so small and so normal that you won't be able to find them during the operation. So there has been a rapid advance of technology to allow us to perform targeted and conservative surgery for this group of patients. So I'll take you through a few slides. These are not my own, these are patients from our Breast Institute, where this lady has a triple negative breast cancer treated with a combination approach of chemotherapy and immunotherapy, and the MRI shows sequential improvement. This is a patient similarly monitored with ultrasound, so you can see that different modalities can be helpful. This is a patient with HER2 positive disease before treatment, after the chemotherapy component, which gave a good partial response, and then after the antibody treatment, which achieved a complete response. And the third case is again a HER2 positive patient, showing how systemic treatment downstages the breast and the axillary disease. We are achieving greater and greater success as we understand more about these cancers. With the advent of dual HER2 blockade using Herceptin and pertuzumab, these are both antibodies targeting the HER2, has allowed pathological complete response rates to increase for this group of patients. Adding carboplatin to the BRCA patients, and in particular, has also helped to achieve PCR results. And interestingly, for a significant proportion, the lymph nodes appear to respond more favorably than the primary breast cancer. So the type of breast cancer is a good indicator as to which patients will achieve a complete response. So in overall terms, about a third of patients who receive neoadjuvant treatment can achieve a complete response. The rates are highest for those who have HER2 positive disease and triple negative breast cancer. But the last line shows you that patients who have purely hormone-sensitive disease can still achieve a very good response, although it's not in a majority of patients. Our group has looked at the response of DCIS. We've reviewed the literature in detail and shown that approximately 45% of DCIS associated with HER2 positive and triple negative breast cancer can also respond to neoadjuvant treatment. So the extent of microcalcifications at diagnosis should not commit you to a mastectomy. It is always worth breast conservative surgery, and if the DCIS has responded, you may be able to avoid a mastectomy. If we go on to the axilla, de-escalation has been important here in the same way that breast de-escalation allows you to avoid mastectomy. For those patients who require mastectomy, they at least have the option of a reconstruction. However, for those patients who require axillary clearance, there is no such thing as an axillary reconstruction. They suffer the morbidity of neurovascular injury and lymphedema. So de-escalation of the axilla has a special place in this talk. So we realized that women who have node-positive disease do not always require further treatment to the axilla. There was a landmark study called the Z11 study, which has been criticized for various reasons, but nonetheless has changed the mindset for women with relatively low-risk breast cancers and relatively low-burden axillary nodes. And frequently now these women have no specific treatment to the axilla and have equivalent outcomes in terms of their overall survival and excellent locoregional recurrence. For those women who have node-positive disease that require treatment to the axilla, surgery is no longer the only option. There was another study called the AMAROS study, which showed that for a selected group of women with cancers that are T1 and T2, with modest number of lymph nodes involved and no adverse features, you could give radiotherapy to the axilla instead of axillary lymph node clearance, and the control rates were comparable, and the morbidity of radiotherapy is about 50% in terms of the risk of lymphedema. Now, the Z11 and the AMAROS studies didn't specifically assess those women who have lymph nodes that are positive with extracapsular spread, and because of that, there's a lot of heated debate about what to do with those women, where the lymph nodes have escaped the capsule. And we currently manage our patients on a sort of case-by-case basis, but we're becoming increasingly more content with axillary radiotherapy for these sorts of patients. Again, our group has looked at avoiding axillary clearance after mastectomy because the Z11 patient population did not include mastectomy patients and they were relatively underrepresented in the Amaros study. But despite doing a pooled analysis of the literature, we're unable to show that there's any survival advantage for an axillary clearance in women who have a mastectomy with relatively low burden axillary disease. So even in these patients, it should be possible to offer axillary radiotherapy and rely upon systemic treatments, providing that they don't have adverse features. So the breast response rate is a very strong indicator of the axillary response rate. So you can see here that if you achieve a complete response in the breast, you can achieve a complete response rate in the axillary lymph nodes in about 24% of patients overall. And similarly for patients who have a higher burden of axillary lymph node disease, you can also achieve a complete response, but that seems to be mainly for the triple negative and HER2 positive disease. The subtype is again important when you're deciding de-escalation of the breast maxillary treatments. So after you have given neoadjuvant systemic treatment to a node positive patient, the question becomes how you sample the axilla. Historically, there has been an approach of performing axillary clearance on all node-positive patients, regardless of their response, but because they achieve a very good response, sometimes that axillary clearance is unnecessary. So there was de-escalation towards doing a targeted approach towards the axilla, and this term targeted axillary dissection has come into the mainstream now, where diseased lymph nodes can be marked with either a clip or a reflector or a localizer, and then retrieved alongside the sentinel nodes during the axillary surgery after chemotherapy. So if you were to do a sentinel lymph node biopsy alone in patients who had node-positive disease, even if they have a complete imaging response, you can have a false negative rate of up to 13%. But if you retrieve the marked lymph node, which has been clipped or tagged, the false negative rate is reduced further, and if you're able to combine the marked lymph node excision with a sentinel lymph node biopsy using radioactive tracer and blue dye, you effectively have three mechanisms to identify these informative lymph nodes, and the false negative rate can be reduced to around 5%. So again, we've reviewed this literature in our group and found that the localization and retrieval rates for these lymph nodes is in the high 90% range, and interestingly, the sentinel lymph nodes are the marked lymph nodes in about 2/3 of patients. But for about 1/3 of patients, the sentinel lymph nodes are different to the marked lymph nodes that were clipped or localized before treatment started. And if you were to omit removing the marked lymph node or the sentinel lymph nodes, you would increase the false negative rate and understage the axilla significantly. So I think if you're going to de-escalate the patient and you want to prove they've achieved a response, you have to make sure that the axillary staging that you do is accurate and targeted. Otherwise you can underestimate any residual disease, and now that has massive implications in all the different subtypes because they all qualify for additional treatments if they still have residual disease. So this is just some pictures to show you how small these operations can become. These Saviscap reflectors are around 7 millimeters in length, so you can see how small the breast cancer surgery becomes and how accurate the lymph node retrieval can be. So the idea for avoiding axillary clearance is that we're able to drive down positive lymph nodes with neoadjuvant treatment, avoid the morbidity of axillary dissection, and even in those women who still have residual disease in those lymph nodes after treatment, there are now studies looking at whether radiotherapy could be effective rather than axillary clearance. And the Alliance study and the Adalnat study from Spain are both addressing this exact question. Because at the moment, if you have lymph node positive disease and you give chemotherapy and you remove these lymph nodes, if there's any residual disease, a lot of centers are still recommending complete axillary clearance. But just because that disease was resistant to drug therapy doesn't mean it's necessarily going to resist radiotherapy. And the risk of there being further lymph nodes involved is also very low. So the advantages of neoadjuvant systemic therapy are to downstage advanced disease, so essentially turn the clock back to a point where the breast becomes conservable and the axilla becomes conservable. In some stages, in some situations, to downstage low volume axillary disease to avoid axillary clearance altogether. And by giving drug therapy to patients while the cancer is still in the body, you're testing the response. And the idea is that if the primary and the lymph nodes are responding, then any micrometastatic disease will also be responding. And we know that micrometastasis is the real target for systemic treatment. And then you can tailor adjuvant therapy. So for example, HER2-positive patients with residual disease can access TDM1, the triple-negative patients can access capecitabine or olaparib if they have BRCA mutations, and the ER-positive patients have access to CDKI inhibitors. So it's really worth knowing if there's residual disease after systemic treatment. And prognostication is important. So if you have patients who achieve a complete response, they have an excellent outcome. And I often say they're as close to being cured as we can get at the moment, which means you could potentially offer them some more hope. And those that have residual disease and have a poorer prognosis would be an ideal group for the early detection strategies that you heard about earlier today. So what will the future bring for de-escalation? We've seen how we've gone from doing radical surgery in all patients to very rarely doing radical surgery and being more targeted, but how can we do even less without harming patients? So this is a study called SMALL. It is looking at the opportunity to avoid surgery altogether for women who have small cancers. And here a radiologist will perform a vacuum excision of the cancer, providing it's less than 15 millimeters and grade 1 without any adverse features, so it's hormone sensitive, HER2 negative. And those patients would then be randomized to either receive radiotherapy only, so that group has no breast or axillary surgery, or to go into standard treatment, so surgery to the breast and axilla, and then adjuvant radiotherapy and systemic treatment. So there may be a group of screen-detected small cancers that just avoid surgery altogether in the future. How about omitting axillary surgery? There is a study called SOUND, which is looking at women with low-risk disease and avoiding any sentinel node sampling at all, because the probability of lymph node involvement is so low, and low levels of lymph node involvement don't influence management. And this study has effectively set a precedent now for avoiding axillary staging in low-risk breast cancer. We also avoid axillary surgery in women who have DCIS, who have mastectomies now, by using MagTrace, which allows sort of delayed mapping of the sentinel lymph nodes. So every opportunity there is to do less breast surgery and less axillary surgery, we're taking it. And then in patients who have neoadjuvant treatment, if they are node negative to begin with, and they achieve a response in the breast, it's very unlikely then that they're going to have lymph nodes that are positive, because those lymph nodes were normal, and the cancer that was in the breast has responded. So what is the chance of those lymph nodes actually showing anything useful at all? So lots of people, including our group, have looked at the literature here. This is one of our recent papers showing that you can safely omit axillary surgery in patients who have neoadjuvant treatment who are node negative to begin with and achieve a good response in the breast. And how about omitting surgery altogether after neoadjuvant treatment? So could there be a group of patients who effectively have a medical type of breast cancer that's diagnosed in radiology, treated by medical oncology, and they never meet a surgeon at all? So these patients are patients who are generally HER2 positive or triple negative. They have neoadjuvant treatment. They have effectively normalized the breast. And if the tissue is normal, we go back to the question, why should we be removing it? So at the moment, the best way to prove it's normal is to do a small operation. But there are studies ongoing, including at the MD Anderson, looking at vacuum biopsies of these tumor beds after neoadjuvant treatment. And if there's no residual disease, these patients have no surgery at all. They just have radiotherapy and then surveillance. So the future is bright for these patients who have HER2 positive or triple negative disease. They're very unlikely to require radical surgery. There's lots of opportunities to de-escalate. So just to bring things together, using research, patient engagement, understanding tumor biology, and advances in systemic therapy, with advances in technology, have allowed us to de-escalate breast and axillary surgery, So from the breast perspective, we've gone from a radical mastectomy to breast conservation to a vacuum excision to potentially no surgery. And in the axilla, we've gone from an axillary clearance to a sentinel node biopsy to a targeted axillary dissection and then to axillary radiotherapy. So thank you very much for your attention, and I've put the contact details there. If you have any questions, don't hesitate